Now coming to the golden rule in the circulation in the post-operative period. There are 4 golden rules. The first rule concerns the ventricle. Second, whether it is parallel circulation. Third is you have a single great vessel and the flow of the vessel depends upon your balance between systemic and pulmonary vascular resistance. And fourth important golden rule is concerning the cardiac output and delivery of oxygen rather than the saturation on the monitor. Now coming to the first golden rule. Here your left ventricle is small and hyperplastic and it is of no use, and you have a right ventricle which is functioning. So functional single right ventricle. So this gives to both systemic as well as the pulmonary circuit, and the systemic circuit flow depends upon your systemic vascular resistance and your pulmonary circuit flow depends upon the pulmonary vascular resistance. The clinical implication is you have to make a nice balance between PVR and SVR to maintain both circulation. Coming to golden rule 2, here there is a parallel circulation. What is very important here is the child faces similar physiological changes before, during and after surgery. Your physiological principle is going to be the same. Third rule is you have to remember blood flows favoring the path of least resistance. If your PVR is low, more pulmonary blood flows happen. If your SVR is low, more blood flows into the systemic circulation. So you have to maintain a nice balance between pulmonary blood flow and the systemic blood flow by altering your vascular resistance. Coming to golden rule 4, here adequate perfusion is achieved by improving your cardiac output and delivery of oxygen rather than saturation. The golden rule 4 implies that we are not changing the physiology but trying to preserve the physiology as much as possible. Now coming to the ventilatory strategy. Here the ventilatory strategy is directed towards balancing systemic and pulmonary circulation. Your goal is to improve your cardiac output, thereby increasing your delivery. For that, the most important thing is the PVR should be high or adequate. It should be never low. If your pulmonary vascular resistance is low, your pulmonary blood flow comes up and your systemic blood flow goes down and there is low cardiac output. If your pulmonary vascular resistance increases, your pulmonary blood flow comes down, your systemic blood flow is high, but at the expense of hypoxia, which manifests as desaturation. Now coming to manipulation in the ventilation to increase your PVR. This you do in situation whenever your QP by QS is too high. That means your pulmonary blood flow is high and your systemic blood flow is low. So if you increase your PVR, the pulmonary blood flow comes down and your systemic flow will increase. In other words, the cardiac output will increase and your pulmonary blood flow comes down if you increase your pulmonary vascular resistance. For that, you can reduce your FiO2 to room air 0.21. Induce respiratory acidosis, hypercarbia by hyperventilation. You decrease your respiratory rate and tidal volume so that your PCO2 goes up and your pulmonary vascular resistance increases. Or you can use high PEEP, which increases your pulmonary vascular resistance by compressing the interalveolar pulmonary artery. Another way to increase your pulmonary vascular resistance is high hematocrit or hemoglobin around 16. This increases the blood viscosity to the pulmonary artery, thereby reduces the pulmonary blood flow. Now coming to manipulation and ventilation to decrease your PVR. This happens in situation where your pulmonary blood flow is low. Here you increase the FiO2, but this increase should be gentle and subtle, because if you suddenly increase your FiO2, the sudden fall in PVR may cause loss of cardiac output due to high pulmonary runoff. You will have lot of blood rushing into the pulmonary circulation and your cardiac output comes down drastically and patient might collapse. Here the goal is to maintain normocarbia and have a mild alkalosis. Sometimes appropriate PEEP and occasionally high frequency ventilation can be used to achieve lung recruitment in patients with poor compliance. Inhaled nitric oxide can be used as a last resort to reduce your PVR.